Hi, everyone. I'm here with someone I'm sure most of you recognize and who needs very little by way of introduction. Cindy Roat, welcome to Founders Messages for membership and those who will soon be members. Let's see. Let's talk about your role in the development of NCIHC, as well as maybe a couple of items that you feel propelled you onto the path towards linguistic equities. What do you think?
Thank you, Eliana, and thank you for giving me this opportunity to walk down a little bit of memory lane and remember those early years of the National Council. In 1991, I was had recently graduated with my master's degree in international public health, finding it hard to get a job back in Latin America, where I had been spending many years doing field work, and ended up starting to work as a freelance medical interpreter to pay the bills. And back in those days, that's how a lot of people got into healthcare interpreting, kind of through the back door. There was no training to speak of. There was no standardized code of ethics, no standards of practice, no certification, for goodness sakes. And it was really pretty much a free-for-all when anybody walked into a hospital who didn't speak fluent English. We were still pulling, as a field, I mean, as a nation, anybody who reasonably we thought might speak the other language, it will be they, a nurse, a doctor, the janitor, the front desk staff, the patient's 6-year-old. And it was just in a few places around the country were we starting to have people starting to think about the fact that not only was this very bad medicine, terrible quality of care for the LEP patients, but it was also illegal under the 1964 Civil Rights Act. And there had been some work done in Seattle at the time, some lawsuits, basically, that's what it took, to get hospitals and clinics to start providing interpreters. And so I started working, as I say, as a freelancer, and fast forward a number of years, and I was working with the cross-cultural healthcare program. I was first hired just 12 hours a week to develop and run a interpreter, once a month interpreter gathering in which there was educated dinner. We always had dinner catered by somebody in one of the ethnic communities of Seattle, and then also some kind of a training on some aspect of healthcare interpreting, usually some medical area, so pulmonology or cardiology or whatever. The cross-cultural healthcare program was then approached by Region 10 Public Health to develop a 40-hour training for healthcare interpreters for the migrant clinics in Eastern Washington. And I was involved in that, and then eventually became the principal writer of that curriculum, along with a team of other people who wrote pieces of it. Mm-hmm. And as the cross-cultural healthcare program got more into this area of healthcare interpreting, Bob Putch, Dr. Bob Putch, who was our medical director and who really should be given the credit, I think, as the founder of the National Council on Interpreting in Healthcare, got a grant from the Kellogg Foundation to bring together all the people around the country who were trying to work on this issue of language access. So there were some folks in Minneapolis, Bruce Downing at the University of Minnesota. There were folks in Boston, Raquel Cashman, for example, Maria Durham at Boston Medical Center, Eric Hart, who I hope we will also hear from in these interviews. And these people were, we were all in our little silos. Remember, this is back before the internet, right?
Right.
So it wasn't that easy to communicate with people. You had to pick up a phone or send them a letter or something. And everybody, there's folks, there were some folks also down in California around Stanford that were working on this, and up in Canada in Winnipeg. And so Bob Putch got this grant through the Kellogg, from the Kellogg Foundation through Cross-Cultural Healthcare Program to bring together this group of people to start a discussion on a national level of about health services to limited English proficient patients and healthcare interpreting. And so we met, and I think people have heard me tell this story perhaps, but I helped organize that meeting just as part of the staff of Cross-Cultural. And it was, first of all, it was truly fantastic to be in a room with this group of people who all understood what it meant to do healthcare interpreting. Because back in the day, it's like, you'd go, I'm an interpreter, and people would go, a what? A who? What do you do again? Oh yeah, you like listen to you like listen to what patients say and try to understand it, right? As well, sort of. You know, the UN, it's kind of like that. Anyway, we got all these people together, and it was very multidisciplinary. We had a number of doctors there, we had researchers, we had administrators, we had freelance interpreters, and we also had a lot of community interpreters, and that was a really wonderful thing, especially from the Seattle area, people who were deeply embedded in their own non-dominant communities, who were there and who were working as healthcare interpreters. And we spent about 2.5 days fighting with each other, because there was a very, very diverse view of what the role of an interpreter in healthcare ought to be. Everything from one end, which was, you know, the interpreter renders in one language what was said in the other. If nobody understands it, it's not our problem. You know, very much interpreter as just the conduit, all the way to the other end of interpreter as essentially social worker responsible for the experience of the patient. Which came from a lot of the community interpreters who said, you know, I live in my community. I have to maintain credibility with my community as well as with the institution. And so, you know, I thought when we left that meeting that nobody would ever talk to each other again, because it became very heated. People were passionate about what they saw as being the role of the interpreter, but it didn't. A couple of years later, I would say the next year later, those of us who were able to attend the first conference of the Critical Link conference in Aurelia in Canada, which was a mind-blowing, like people from all over the world who understood what community interpreters do. It was incredible. Those of us who were there stayed late to review, at the request of the MMIA, the Massachusetts Medical Interpreter Association. That was Jane Contreras and Maria Paz Avery, who had worked with a committee to put together the first standards of practice for healthcare interpreters. And they asked the folks from the council if we would, you know, they were part of the group that had met. We weren't the council, we were just this group of people. And they asked, would we review it? And so we did, we sat and reviewed it. And I noticed that everybody had moved off their position. Everybody had moved a little bit towards a more central view of what the interpreter could do. Maybe we needed more flexibility than just the conduit, but maybe we recognized we weren't the people responsible for the health care of the patient, right? You know, that our principal focus was the communication, and that's where we had to draw some boundaries. And so we met then, and then a year later again in Boston, right before the first conference of the Massachusetts Medical Interpreter Association. We all got together and met in I think it was like a Benedictine retreat center. It was very interesting. And again, we started, you know, we ended up discussing the same issue about the role and other things. And finally, the following year, which was 1998, we met again back in Seattle. And every time the group grew. I should definitely emphasize that. It wasn't just the same little group of people, because it was very much word of mouth. You know, who do you know who's doing this work? Who do you know who's doing this work? Oh, let's invite them. Oh, I heard there's somebody doing something in, you know, wherever. Let's invite them. You know, what about New York? There must be something in New York. So little by little, the group grew and grew and grew, and we had more people. We had policy people being invited. The Office for Civil Rights attended almost every time. We had people from the Office for Civil Rights. They were very interested in this work. And eventually in 1998, at the end of that session, the question came up, do we want to keep meeting? And I don't remember who it was in particular who said, we really need to become an organization. We need to have some structure, and we need to be able to attract funding, and we need to continue this work. And so a small group of us were elected to be kind of like an interim organizing committee to put together a straw man, a draft of an organizational template, and then to find funding to meet the following year, which we did in Monterey, California, with funding from Language Line Services, I will say. And Language Line Services was very generous. They funded that meeting, and they agreed that they would have no input into the agenda.
Wow.
So they didn't control the agenda at all. They simply funded the opportunity for people to get together. At which point we debated the draft, we voted on it, and we elected our first board of directors. And I was honored to be elected as co-chair along with Julia Puebla Fortier. And that's kind of how the council got its start. So to me, the question of, kind of what attracted me to this work was, it was always the social justice issue. My first career, as people may know, was in international rural development. I worked for many years in very isolated parts of Latin America, trying to help very poor communities organize and find funding to develop projects that were important to their health and economic well-being. And so coming back to the United States, I continued, to me, this issue with language access when I got into doing interpreting. To me, it was very clear I was working for the same people.
Right.
In some cases, the exactly same people, which was kind of freaky sometimes, that I would turn out that I knew somebody. I would be working with a patient. It turns out I knew her mother in the Mosquito Coast of Honduras, and I had seen her more recently than she had. So it was the same population. It's just the population here as opposed to the population there. And the population that I worked with in Latin America, the barriers to getting good quality healthcare were largely financial and logistic. There were no doctors that were accessible. Everything was too expensive. Here, there are many of the same barriers, but I think one of the key barriers is this linguistic problem that people would come and they either had no interpreter or they were supposed to bring their own interpreter and nobody was trained. And, it became quite clear to me when you started training interpreters that you started to see a vast difference in the quality of and the accuracy of people who had actually thought about what they were doing as interpreters and had learned techniques for becoming accurate and complete, compared to, the ad hoc interpreters who, God bless them, were doing the best they could for their communities with no support and no training at the time. So I have been very proud to be part of this movement in the United States, along with many other extraordinarily talented people and dedicated people throughout the last 30 years, building some degree of agreement. We never came to total agreement about the role of the interpreter. Also, to develop a national code of ethics, a national standards of practice, a national standards for training programs, and what has eventually led us to national certification. So we see what, when I started, was just an ad hoc activity is now becoming truly a profession. And I feel that every time a patient walks into a healthcare center and has a professional interpreter provided over the phone, over the video, over in person, I feel like we have made steps forward, and that makes me very proud.
As you should be. I think of the challenges, as you mentioned, before emails, before internet, and still managing to gear up and get together coast to coast from country to country even. And so we all thank you, because none of us would be here without the impetus as well as the professionalization of something that maybe we had also been doing with no guidance, no training, and just floundering along the best we could, trying to help our families and our community. So thank you, Cindy, and thank you everyone who participated in that first meeting that grew eventually into NCIHC. Ciao for now, folks.